Good afternoon, everyone. Hi, everyone. Good afternoon. Thank you for joining us today. Diva Animal Health is delighted to welcome you all to today's session, where we are joined by Dr. Roberto Santilli, who shall present new perspectives in the treatment of pulmonary edema very shortly. Today, we are joined by veterinary colleagues from across Europe, including Belgium, Germany, Spain, and the UK, to name a few. My name is Natalie Borrell, and I am the UK Veterinary Advisor for Cardiology, Nephrology and Hypertension here in the UK. I am also joined today by my colleagues, Alessia, Alexandra, Emily and Catherine, who will be assisting us during this for the next hour. And I would also like to take this opportunity to thank everyone who has been involved in organising this international event today. Before I formally introduce Dr. Roberto Santilli, I would like to go over some housekeeping points for today's event and show you how you can use the Blue Jeans platform for this session. And the good news is, it's very straightforward. In the top right corner, you can see there are a few icons. For any technical issues or difficulties, please interact with our moderators who will help you promptly. And the place to go to is the icon where you can see a person with a speech bubble. If you would like to ask questions during the presentation and at the end, then please go to the icon where you can see Q&A and write it in here. We will then gather all the questions together and ask them at the end of the talk. Lastly, Dr. Roberto Santilli will ask an interactive question during his talk. When he asks this question, simply go to the poll section, which is represented by a bar chart in a box. Also, please be aware there will be a red light to indicate the poll is live. So you'll be aware when this happens, and don't worry if you forget, as I will come back on at this point to remind you how to. So now it is with great pleasure I introduce Dr. Roberto Santilli. Dr. Roberto Santilli graduated from the College of Veterinary Medicine of the University of Milan. He became a diplomat of the European College of Veterinary Internal Medicine, Companion Animals Specialty Cardiology in 1999. Between 2004 and 2006, he completed a Master in Electrophysiology and Electrical Stimulation at the University of Medicine of Insubria. He then obtained a PhD at the University of Turin, College of Veterinary Internal Medicine in 2010. Roberto is currently head of the cardiology departments of the Malpensa Veterinary Clinic and Portoni Rossi Clinic in Bologna, Italy. And since 2014, he has been an adjunct professor of cardiology at the Cornell University College of Veterinary Medicine, where he is actively involved in the activities of the Cardiac Electrophysiologic Laboratory. He is also co-author of the book, Electrocardiography of the Dog and Cat, which is now translated into 7 languages. His main research activities include the diagnosis and treatment of arrhythmias in dogs and cats. Please join me in welcoming Dr. Roberto Santilli. Over to you.
Okay, thank you very much, Natalie. Good afternoon, everybody. So in the next 45 to 50 minutes, we are going to talk about new perspectives in the treatment of pulmonary edema. As you all know, pulmonary edema, by definition, is an accumulation of fluid at the beginning in the interstitial space, and then, in severe cases, into the alveolar lumen. The major determinant for the increase in the formation of edema is an increased hydrostatic pressure. And you can see from these graphs that this is the left atrial pressure and this is the lung fluid. You can see that above 10 millimeters of mercury in the left atrium, you have a rise of the fluid accumulation, and also you have an increased death rate. So the left atrial pressure is one of the major determinants that induce increased hydrostatic pressure. We have several compensatory mechanisms try to to decrease the amount of edema. So the most important one is the increase in lymphatic flow and drainage. There is also a reduction of the interstitial oncotic pressure, so-called oncotic buffer mechanism. There is a high interstitial compliance and the presence of surfactant within the alveoli. There is some experimental studies that shows that in chronic situation, the pressure within the left atrium can rise over time. And this compensatory mechanism can avoid the formation of at least of alveolar edema or and partially of interstitial edema. As you can see from this table, this is the ratio between the left atrium and the aorta. Starting from a normal ratio, you have a kind of normal left atrial pressure, but then over time, if the left atrium size increase, you can also see a rise of the left atrial pressure without an evident edema. So another important compensatory mechanism try to avoid edema is the enlargement of the left atrium. This is part of the EPIC study results, and this is a way to try to predict the onset of pulmonary edema in dogs with chronic mitral valve disease. As you can see from this graph, this is the vertebral heart score, and this is the months before the onset of congestion and edema. And you can see that cases that will go into congestion over time, they usually reach the 12 vertebral heart score and around 6 months before the onset of edema. So we are now using this type of criteria when we do recheck in cases with mitral valve disease, because we can now know at least with we can try to understand when the edema will occur according to the vertebral heart score result. There is other way to try to understand if edema is coming, so it's forming, and the respiratory resting respiratory rate is one of them, has been shown either for dog and for cat, and usually in case the animal has neither interstitial nor alveolar edema, this resting respiratory rate should be less than 30 breaths per minute. And also under treatment, so when you use any loop diuretic, as we will see in this talk, you have a respiratory rate, so a resting respiratory rate less than 30. So I think this is, probably all of you already are using this. It's so important. Try to teach to the owners how to predict the onset of edema. Then, obviously, chest X-ray are the best way to diagnose pulmonary edema, together with the point of care lung ultrasound. But obviously, for most of us, the edema is very can be clearly seen using chest X-rays. So here, or your left-hand side, you can see a cardiomegaly. This is a dog with mitral valve disease. And then you can have an increase of pulmonary density diffuse, but you can still see some vessel. This is the classical features of interstitial edema. And during this talk, I will try to suggest to you to differentiate quite well these two types of edema, because I think we have some chance of different treatment according to the severity of the edema, and therefore if it's more interstitial or if it's more alveolar. And then obviously in the severe case, when the fluid go also into the alveoli, you can have alveolar edema with, air bronchogram, alveolography, and so on. And this is a kind of zooming of the interstitial with increased density and compared to the alveolar, where you see the presence of air bronchogram. This is also the difference between dogs and cats. Here you see an alveolar edema, mainly interstitial with some rare area of alveolar here, because you can see some air bronchogram. And you know, usually it's a diffusion that goes dorsally, starting from the hilar region, while in cat is more diffuse, it's irregular, can go more ventral than usually does in dog, that go dorsal and caudal. Here are some example of paper written on pulmonary edema for dog and cats. For example, this paper explain that edema in dog, it can be either bilateral, just like in this case, or can be more on the right hand side of the thorax. In cats, it has been shown that using the vertebral heart score, particularly if you have a vertebral heart score more than 9.3 vertebra, usually this is enough to suspect an underlying cardiomegaly and therefore the presence of dyspnea due to cardiac disease. So what other way to diagnose congestion in dogs? Obviously, again, chest x-ray is the best, together with lung ultrasound, but you can also try to use echocardiography, try to stage the amount of increase in left atrial pressure indirectly, and then try to check over time using loop diuretic if we are decreasing the preload and so helping the animal in draining the fluid from the lung. And obviously the presence of an increased left atrium to aorta ratio is one of the best way to diagnose congestion, particularly if you use a cutoff of more than 2.5. This has been shown by this paper of Schober, and then there is other more that use more cardiology, some ratio of measurement of the transmitral flow velocity and the time of relaxation and of the isovolumetry relaxation, as you can see up here. Then there is also some other data that you can use. Again, the respiration, the respiratory rate. The NT-proBNP can also be used. You see the difference between group with and without congestion. We use the E to A ratio. This is the mitral inflow velocity, can help you understand if there is an increase left atrial pressure. And again, this ratio between the the E of the transmitral flow velocity and the isovolumetry relaxation time. Then there are some new echocardiographic measurement that is being published recently. So the ratio between the right pulmonary vein to the right pulmonary artery, you do from the right parasternal long axis view, optimized to see the right pulmonary artery and right pulmonary vein. Usually, if you have this ratio, you can also use it in cat. In cat with heart failure, usually have the cutoff that seems to be quite good is around more than 1 to be considered abnormal, and you can see something around 1.2 to 1.5 to be considered that there is congestive heart failure. So let's now start to talk about treatment of pulmonary edema. I want to show you this slide because for human it's very important to stage the disease, but together with that you need to stage the left ventricular function. And that's why you have congestion in different situations. You have with a reduced ejection fraction, for human is less than 40%. If mildly reduced ejection fraction from 40 to 45, and then if you have a preserved ejection fraction is for more than 50. Why is this important? We don't have time during this webinar because we really concentrate on some news about treatment using loop diuretics, but if you have a dog with congestion, you should keep in mind this type of drawing. So you can be wet, so with congestion, and you have the dog that is warm, so with a normal ejection fraction, or you can have the dog that is cold with sign of congestion together with sign of hypoperfusion. And I put for you some example here. The classical mitral valve disease dog usually is wet and warm, so maybe during the acute treatment of edema, you will start using loop diuretic together with oxygen. But then if you have a particularly cat with severe mitral valve disease, with severe dilated cardiomyopathy, at this point, it's better to use furosemide together with dobutamine to help having a better systolic function. And in these cases, we have very good results using the combination of the two. So how we treat pulmonary edema? Obviously, I put here for you A is for acute and C is for chronic. And again, we will concentrate mostly on loop diuretics. But in the acute setting, you use, depending on the stages and the severity of the edema, you can use different loop diuretic. Then you can use pimobendan, either in the acute and obviously in the chronic stage. Obviously, in the acute stage, oxygen therapy, sedation, and if you have a wet and cold, we do use dobutamine, as I just explained to you. About nitrates, there is no consensus, as you know, looking at the guideline published last year. And then ACE inhibitor, usually for more chronic treatment, together with the anti-aldosterone drug that are used for the more chronic treatment of edema. So let's see very rapidly what we know about stages and treatment. So according to the 2019 ACVIM consensus guideline, we usually in stage C in the acute treatment, and again, we are just talking here about wet and warm. So there is an expert opinion about the use of furosemide. You can either use, according to the severity, either just IM, 2 mg per kg, or you can go then with different boluses over time, and for a maximal total dose of 8 mg per kg in 4 hours. Or, as we prefer, we really like to use CRI, furosemide, 0.666 up to 1 mg per kg per hour after the initial boluses. There is not consensus for that. It's a weak level of evidence, but in our units, we are treating several animals using the CRI, and together with IV pimobendan in the acute stage of edema. I'm talking right now about alveolar pulmonary edema. And in this case, the CRI of furosemide, I think it's mandatory to have a faster recovery of the animal. In the chronic stage, the guidelines suggested to use usually 2 mg per kg of furosemide twice a day, and sometimes they try to change using torsemide. So the guideline right now, they are not still suggesting to using as first-line treatment torsemide, and together I can show you something that maybe we can in the future think also about this possibility. And we will talk a lot about torsemide, this new drug that can be used in dog, and so we will also see about dosages and timing. And when the amount of furosemide per day is more than 8 mg per kg, then, or an equipotent dose of other loop diuretics, this is called class D. And at this point, we have to check about diuretic resistance. And I have a few slides for you how to try to stage this diuretic resistance in dogs with mitral valve disease. In stage D, the acute treatment, in absence of renal insufficiency, we can use additional furosemide boluses, and then again you can either use boluses or a CRI, try to stall also the reoccurrence of edema in this animal. And then in class D, and that's probably where we started with torsemide, most people are now using torsemide in a case that furosemide is not working, or if we are suspecting diuretic resistance, and at that point we change it to torsemide. And then again, maybe we have some studies now that are showing that we can also use maybe in the early stages. In class D, other treatment that can be done is, if it's not yet used, to add spironolactone. As you know now, in class C, it's already used. Right now, I'm just talking about the diuretics, and that's why I didn't put pimobendan, ACE inhibitor, and so on. But as you know, starting from class C, most people use already now spironolactone, and you know that there are also some new studies that are suggesting that maybe looking at the results of the delay study, maybe we can also try to anticipate the use of spironolactone to class B2. And then in very, very end stage, you can use hydrochlorothiazide and together with furosemide or torsemide, and you can use maybe every other second or fourth day, because you know there is a severe impairment of renal function and marked electrolyte disturbances using this sequential nephron blockade. Okay, this is my question for you. When and in which stage right now you are using torsemide?
Okay, thank you, Roberto, for the talk so far. And it will be very interesting to see how people are currently using torsemide at the moment. To answer this question, please go to the poll icon in the top right of your screen, which is a bar graph in a box with a red circle indicating it's now live. When you click on this icon, you should be able to see the question: in which stage do you use torsemide? And the options are: I don't use, stage C, stage D, or both C and D. I'll give you a moment to put your options in there and answer, and then I will update you in a second, Roberto, with the results.
Okay, thanks a lot.
Votes are still climbing at the moment, so I'll let it run for a few more moments. Okay, so 54% are using it in both stage C and D. 5% are not using torsemide, and then it's split between stage C and D at about 20% in each stage.
Okay, thanks. So we have a rough idea now in how you are right now using torsemide. So we can now talk about the use of loop diuretics in case of animal with dyspnea and suspected or obviously confirmed pulmonary edema. And my question is right now is we can actually try to stage it and say it's a severe edema or it's a moderate edema. There are several studies that are trying to do some, number, trying to say if it's more severe or not. But I think the most important try is to differentiate according to the pathology of the edema is if it's more interstitial. So we are maybe, all the compensatory mechanisms are not enough to drain most of the interstitial, so the animals start having dyspnea, or if it's already alveolar. I mean, if it's alveolar edema, we don't have any doubts that we have to go for IV furosemide, and my experience is very, very good with the CRI, but I'm not saying that intermittent boluses are wrong. I'm just saying that our experience is very, very good with CRI of furosemide for the alveolar edema. So here is a possible scenarios for a dog with mitral valve disease in the acute stages. This is a cavalier in different stages of the disease. On your left-hand side is polypnea, starting dyspneic with sudden onset with the resting respiratory rate of 50. And then on the other hand is a dyspnea with, again, with the sudden onset, and now the resting respiratory rate was 65. I mean, if it's severely, and the clinical sign will help you together with the chest x-ray, you can stage it if it's more interstitial, and you can maybe go for one type of treatment, or if it's more alveolar and then you don't have doubts, and then you go for CRI or furosemide. And so obviously we have several treatments for edema, as I already listed for you, but loop diuretics are the drug to pick. Why is that? Because as you see from this drawing, it's usually 25% of the sodium retention is down here in the loop of Henle, and therefore the use of loop diuretics is the way try to use and to reduce the reabsorption of sodium. As you know, we already talked a little bit about thiazide, but we use spironolactone for different reasons, but again, is not a diuretic for dog and a different dosage. So we should not consider it as a diuretic. There are several studies showing this. So we know that there is few studies about furosemide, so I'm not going to talk a lot about this, but just few slides for you, trying to make you understanding why furosemide is important. So we have here that according to the doses, we have the potencies that change. So it's more potent if you give high dose, and then the left atrial pressure decrease. And again, also it's important that over time, using furosemide, you obtain a decrease of the preload. And then there is another point that has been shown, that usually if you use boluses, the circle, or CRI, the triangle, you have different data, because the circle, as you can see, you have a peak and then a decline, then another peak. But then if you use CRI, you have a more stable effect. And as you can see here, CRI has more urine output. Then the problem with all the loop diuretic is the activation of the RAS system. And has been shown that is present in either with furosemide, you will see also with torsemide. And the problem is that with CRI, we have less activation. And the volume using the furosemide over time, you must be very careful, because sometimes if you use high doses, you can induce what we call the break-in phenomenon. And what is that? Is a rapid activation of RAS with a decreased production of urine and increased aldosterone. And that's important because in some cases, particularly in cats, despite the high use of IV furosemide, there is no possibility to obtain a good production of urine. So there is several reasons to use furosemide in class stage C. Is a first line in case of acute alveolar pulmonary edema. We prefer CRI, but you can also use intermittent boluses. So I explained to you probably why we prefer CRI, less activation of RAS system and more production of urine. Possible break phenomenon if you use very high dose. So that's why we really like CRI with a stable over time doses. And we really like to use in class C together with PMO and ACE inhibitor and spironolactone as suggested by the guideline. Let's move now on torsemide, the new drug. So there are several studies on PK/PD about torsemide. And as you can see here, this is the usual comparison that we do, is 1/10 of the furosemide dose to obtain a more potent diuretic effect. So torsemide, we all know that is more potent, but another important thing is the potency of furosemide depends on the dose. So usually if you stay low dose, so it's about 1.2 is 110, but then if you go up to 0.4 doses, then you get 120. So that's important. You will see there are some studies that use very high dose of torsemide at the beginning of the study, and then they decided to go down with the doses. And what I really would like to do for you today is try to suggest how to use torsemide according to the severity of edema and to change doses according to any possible reoccurrence of edema. This is a new study that showed that for a daily target diuresis of, for example, 460 ml per dog per day, so in a severe alveolar edema, we should use a doses around maximum of 0.26. And the equivalent dose is 3.5 milligram per kilo per day. But then, if you want to have a more potent effect, you have to increase the doses up to 0.3. There are cases up to 0.4, but this should be limited to maximum 3 to 5 days because there is very, very high inter-individual variability in the diuretic effect. And so here, if you use for a longer time, we can have problems. Again, I'm talking about class C, and that's very important because obviously when we talk about class D, I mean, we have cases that are very severely affected, and so we can take also different decisions. And using the more we use, the more high dose we use, the more diuresis we obtain. You can see the volume here. But again, if you go too high, and we want to go high if we want to solve a reoccurrence of edema, but not if we want to use long-term a class C patient. And exactly as all the other loop diuretic, we have also an increase in the aldosterone concentration using torsemide. And we will talk a little bit about also the anti-aldosterone effect that this drug can have, or we suspect that this drug can have. This is another study about the use of torsemide because, I mean, all of us were at the beginning of the use of this drug, we are so, good with furosemide. We were afraid that torsemide is damaging the kidney. And so this is the first study that they try to understand if this is the case. And then if you go here, you can see that there is for torsemide and for furosemide, if you go to the use of creatinine was very similar, phosphorus was very similar. So there was no a major effect, obviously using the correct dose. I think that the problem with torsemide, we have to be confident that we really need to use, according to these stages, to use the right dose. And if we do this, I think we don't have major problem. This is another study that's been done, and I think most of you had read it. So is the test study. In this study, they wanted to show that torsemide was not inferior to furosemide. And they actually show that. And they also show that if you use the right dose at the beginning, as you can see here, they use a very high doses, and then they reduce it using the current dose that most of us are okay in using. So the usual low dose controlling edema chronically in patient in class C. In this study, there was more renal effect than furosemide, but again, because they used a higher dose, and also they have, as you can see here, some effect on the iris stages, but was not too different from the one obtained with furosemide. So again, it's very direct related to the dose. And now I want to talk about these two major studies by SIVA about the use of torsemide in dog. And one is a short-term safety and efficacy test. And then another one is just the continuation of the carpodiem. It is called SAFE-DM, looking at the safety long-term of the use. As you can see here, this was used for up to 84 days, this one up to 168 days. And again, you see the low doses, 0.13, and then they go for a maximum of 5 days up to double dose, so up to 0.25. And then with furosemide, they use the doses proven in the previous study that I show you that can obtain at least, half liter of urine production. And then they continue over time and they check the safety up to, again, using the lower dose to control edema compared to furosemide. And so according to this study, we had these kind of ranges that I suggested to you. The initial maintenance dose in a mild pulmonary edema, again, to me, is what I consider interstitial with the dog. That is the dog that you usually treat with IM or subacute furosemide, and you go and you send it home. And compared to the dog with alveolar edema, you keep in the ICU using CRI of furosemide or boluses of furosemide. I'm sorry. And here we have the dose is from 0.13 up to 0.25 mg per kg once a day. You all know that this is a once a day drug. And temporary, you can use high dose from 0.26 up to 0.4 per kilo per day in a once a day dose up to 5 days maximum. And in here again, we had a larger inter-individual variability and increased urine volume over time. So you cannot go more than 5 days in class C using torsemide at these higher doses. And this is the group of furosemide and izimide group. And you can see the ages was a matched group, and they also, according to the different breeds, different gender, and different heart failure stages. And then there is the staging of edema. Mild was mainly interstitial. The moderate has few alveolar just in the peripylar region. And then you have the severe one again. That was the one requiring more aggressive treatment because it was alveolar edema. And that's the FETCH score, is the questionnaire that most of us is using, try to understand from the owner the condition of the dog over time and see the response to treatment. And then you have the BHS, and then you have the ratio between left atrium and aorta and all the echocardiographic parameters. And as you can see here, in short term, safety and efficacy, torsemide as a first-line treatment could control edema quite well. And you can see the radiograph of edema over time, starting from the green and the was radiographed within normal limit, and then you have mild, moderate, and severe. And you can see that over time, obviously, there is a progression of the disease, but you can see that using torsemide, so izimide, you can see there is more green than other using furosemide. And then, according to the events, so the occurrence of cardiac death, euthanasia, or premature withdrawal from the study, they show that using izimide, there was a good survival probability, and so was for sure not inferior to furosemide using as a first-line treatment. And so it's not inferior to furosemide. And then, according to the multivariate analysis, torsemide using, the comparison between torsemide and furosemide, as you can see here, the hazard ratio was quite good for torsemide. Then if you look about this graph here, the NT-proBNP decrease over time using this drug, and also the FETCH study decrease. Obviously, you know, the green is the izimide and the yellow is furosemide. For both cases, there is a better lifestyle, but then you can see that in both cases there was a control, but torsemide was very good in this setting. So according to the Carpodian, there is need to increase the dose of furosemide, was around 7%, and around with izimide was just 1%. Owner compliance at D14 was 98% for izimide and 92% for furosemide, and acceptance of the drug without food was almost 30% in izimide group and 8% in furosemide group. So according to our, what we are very, very afraid about renal parameter, at D4 in asymptomatic cases about renal disease, but we have a rise of the parameter and they remain stable and decrease by D14 without need of withdrawal from the study. And so for the safe DM, so we just go long term. And long term, we have that the use of izimide compared to furosemide. As you can see here, in the problem linked to the use of furosemide was 23/23, and for izimide was 94% safe. So there is no real difference. And also if you go for renal urinary disorder, you can see from izimide was 29% and furosemide was 21%. So there was no real difference between these two drugs. And so we can, I think that according to this study, we can use also torsemide as first-line treatment in dogs with cardiogenic edema, as a first-line treatment. Here you see the urea that is kind of stable over time, and also creatinine that was stable over time. Now I want to show you in the first part of my talk something about what we are doing right now in Italy. So is the efficacy of izimide as a first-line treatment in pulmonary edema in dogs with congestive heart failure due to mitral valve disease. So we want to evaluate the effect on clinical sign and quality of life using the PET score, compliance of the treatment of at day 0 and day 30 as a primary, and at day 30 and at day 60 as a secondary. We are enrolling 10 cases for each of the 10 Italian centers that we picked, and then we want to get at least 100 dogs between 22.5 to 60 kilo. With the new onset of interstitial edema, so at least should be an edema that it does not require CRI or boluses of furosemide. And they can be either on PIMO, ACE, or spironolactone, but to enter the study, they should not be on furosemide. And the VHS more than 10.5, the ratio, this is the usual delay and EPIC criteria, so LAAO more than 1.6, and the internal diameter in diastole of the left ventricle more than 1.7. And the important, we want a dog without underlying renal problems, so we pick the IRIS cutoff of 1.4 for creatinine. And so right now it's just a pilot study that I want to show you because of the COVID we couldn't enroll a lot of cases, but our plan is keep going. And now in Italy, as you all know, COVID is much better here, so we are now getting almost back to normal, so we are enrolling much more cases. But here we just want to show you some data about these 6 cases. So breed, Cavalier, Jack Russell, and Chihuahua, gender here, the age, the body condition score, and the body weight here that you can see. And right now, one case is at 61 days, so just at the end of the study needed a CRI of furosemide, and so was excluded, and one was lost of follow-up because of the COVID. So we will talk mostly about these 4 cases just to show you when he came. They got, this is a score, 1 to over 3 of cough, and we had a lot of cough, 2 out of 3. 1.5 out of 3 for dyspnea and 1.16 out of 3 for exercise intolerance. The fetch average was, the median was 19 with a respiratory rate at rest of almost 60. We had echocardiography with this data. We also included 1 dog with atrial fibrillation, and this was the dog that actually exited the study because of reoccurrence of edema. And this is our protocol. We use izimide in these dogs, and we did a D0, this exam here, and then as you can see here, at D4, 14, 25, and 60. So we wanted to see over 2 months the physical exam, fetch, electrocardiogram, chest x-rays, echocardiography, and blood work and urine analysis and respiratory rate. So we use in the acute onset edema 0.13 up to 0.25, and for a few days in case of reoccurrence we go up to 0.4 for a maximum of 5 days. And this is all the cases that you can see when they came in. Up you can see the different stages of interstitial edema with the resting respiratory rate. And this is, you can see quite nicely in most of the cases, the presence of edema, particularly in the right side, as what usually happens in dog. And this is just 1 classical cases. We are now enrolled 3 more cases. And you can see at D0, at D0 we have 3 out of 3 for cough, 2 out of 3 for dyspnea, fetch 17, and resting respiratory rate of 74. You can see interstitial edema and cardiomegaly. We started with 0.15 once a day of izimide, and obviously together with the other drugs. At D5, we have cough, dyspnea 0, fetch 2, and RR, resting respiratory rate 32. And then at D25, it remained stable, and at day 16, it was stable with a little bit more increase in cough. But we know that most of the time it's not related just to edema. And here, some graph for you about cough score, dyspnea score that go down over the 2 months, the fetch that again go down over the 2 months, and the respiratory rate that become within the limit. And then urea and creatinine, again, in our study, we just recheck. I know that maybe you may be scared about it, but we hadn't any problem just checking in case, obviously, before starting, you need to have a creatinine less than 1.4, but then you don't need to recheck every day the creatinine in the urea. So we did it just at the end of the study, and there was just a mild increase with below the iris limit for renal insufficiency. So there are several rationales to use torsemide, in my opinion, in class C. It's 10 to 20 times more potent than furosemide, depending on the dosage. Remember, low dose is 110, high doses for a few days, 120. Possible use as a first-line treatment in cases of acute interstitial pulmonary edema with a single daily dose. Efficacy and safety is similar to furosemide in a chronic control of pulmonary edema, and less RAS activation than furosemide, that has been shown. We have some idea about aldosterone antagonism, but we need more study. For sure, my personal experience that we are using now for several months, and there are in chronic cases we found less diuretic resistance compared to furosemide, but we need more study to confirm that. It does not induce renal insufficiency if you use the right dose, neither in short nor in long-term use. But again, this depends on the dosage. So it's very important that you respect the dosage according to the timing and the stages of the edema. So now I can finish the 5 minutes about talking about the class D and when we have diuretic resistance. And so we can say something about loop diuretic also here. So diuretic resistance is when, despite the use of furosemide and less about, again, torsemide, because we have less diuretic resistance, but still, if you have loop diuretic resistance, and if you have, still edema despite the use of loop diuretic, ACE inhibitor, pimobendan, spironolactone, the first things you have to think is the non-adherence to the diuretic treatment. Be careful, because sometimes, and it happens several times to me, that we're thinking that the diuretic is not working, but actually the owner is not giving properly, and because it's changing the dose or is giving in some wrong way. Then there is what we call the early breaking. So sympathetic activation induces sodium reabsorption from the proximal tubule, and this is a very important in the acute phase of congestion. The early breaking should be considered, but then you have what we call the late breaking. The chronic use of loop diuretic, mainly proven with furosemide, induces hypertrophy and hyperfunction of the distal convolute tubule cells, inducing reabsorption of sodium. So despite the use of furosemide, we have either the early breaking, the breaking phenomenon with the activation of RAS, and then you have the late breaking, where you have anatomical changes of the distal convolute tube. Then we have the counter-regulatory effect of aldosterone, what we call the aldosterone breakthrough. I will talk a few slides about this. Then excessive contraction of the extracellular volume with secondary increase of solute and fluid. And that's when we use very, very high dose for longer time. And then inconsistent diet and water of the water and sodium. And again, there is no good data about using low sodium diet, but we have to consider to check about it, and also to check about the amount of water that the dog is drinking during diuretic therapy. And finally, malabsorption of the molecule, and this is important because of intestinal edema, and we found, particularly in dog in stage D with ascites, and in this case, the use of subcutaneous furosemide is maybe important, together with the use we will see about torsemide, as is suggested by has been suggested by the guideline of 2019. So the aldosterone breakthrough has been shown in several cases, despite the use of the ACE inhibitors. You can see that over time you have activation, increase of the urine aldosterone to creatinine ratio, sign of aldosterone increase in the bloodstream. And by definition, the aldosterone breakthrough is the increase of aldosterone above the population limits, despite the use of ACE inhibitor. The prevalence is around 32% in dog with congestion and 30% in dog without congestion. And the causes is inadequate blockage in 30% of the cases, because they are not giving the exact dose or missing the administration. There are alternative pathways for the RAS activation. You will know about that. Increase of potassium and renin, and then the use induced by use of loop diuretic and vasodilator. Also for the aldosterone breakthrough, there is a new study where they tested the ACE gene polymorphism, and they looking for different metabolites, because there is a particular metabolite called the 17 metabolites for this gene, and this is usually a kind of protector of malfunction of this gene. And they found that if the dog has a polymorphism for this ACE gene, there is aldosterone breakthrough in 54%. And what is important, there is also an increase in the aldosterone-angiotensin ratio, and this will suggest to us there is an independent aldosterone production. So when we use ACE inhibitor, we have to keep in mind that most of the time, enough of the cases we can have from 30 to half of the cases, 30% to 50% of the cases, we can have aldosterone breakthrough. So it's important to consider the use of, again, spironolactone, or consider all the other causes inducing this. So why we should use torsemide to replace furosemide, or in some cases together with furosemide in class D. Here again is very potent, and maybe there are some questions about it, but in stage D, obviously we have to keep the animal alive and trying to keep him alive as much as we can with a good quality of life. But obviously at some point we should use higher dose of torsemide, because otherwise we cannot control a severe edema in such a cases. The possibility to replace furosemide with a maintenance dose of furosemide, or torsemide, there is less activation of RAS and possible aldosterone antagonism that has been proven, and in my personal experience, less diuretic resistance compared to furosemide. And so there are probably a concomitant effect about, anti-aldosterone. We don't know about this, or because it's just more potent, maybe because it's not inducing the delayed breaking effect, we don't know. But in my experience so far, using torsemide over time in this last year, we are really seeing much less diuretic resistance. Thank you very much for your attention. This is my contact if you have any question or doubt, and I'm now happy to entertain any of your questions. Thank you so much.
Hey, thank you, Roberto, for a fantastic talk. It's been very interesting to hear your experiences in using torsemide and how it compares to furosemide. We have had quite a few questions, so I will find the first one that's been asked. So somebody has asked, they are already using torsemide in dogs in stage B2, where there is moderate to severe diastolic dysfunction, but without clinical signs. Is that okay, or would you use furosemide in these cases?
Okay, thank you for this question, Gregory. And I think B2, is a very, very open, discussion, because B2, we know that now there are several possibilities, try to slow the congestion, but for sure these patients are already in failure. They are in failure maybe without congestion, but they are in failure. And when you have advanced B2, I think this can be an option to use torsemide, or because in such a case we usually use low dose furosemide, and since there is no need of CRI of furosemide, I think the option of using torsemide, I think is a good one.
Okay, thank you. The next question was, you showed a graph of survival and outcome with torsemide versus furosemide with a statistically significant difference. What was the actual difference? Was it a clinically significant difference?
Maybe there is also the coordinator of the study, so Emily and Catherine. I don't know if you want to give some clue about the graph that I show. Do you need to review the graph, or are we okay to just to discuss about it?
Hello everybody. I'm Emily. I'm the technical manager, global technical manager for the cardiology, nephrology, and hypertension range in EVA Corporate. So regarding the curve that Roberto has presented, so the survival curve, there is a significant difference. So the figure which appears on the slide is the p-value, which is the log rank test, showing that there is a statistical significant difference between both groups, meaning that if you look at the curve, in fact, dogs in the torsemide group have about half less risk of dying or worsening for congestive heart failure when they take torsemide, in fact. So yes, the difference is significant, and you see that the risk is divided almost by 2.
Right.
Thank you, Emily.
Thank you, Emily.
Roberto, someone has said, thank you very much for the presentation. It's been fantastic. They did observe that the izimid versus furosemide trial used perhaps a lower dose than we would routinely use for starting cases with heart failure. Do you think that this influenced the survival curve as dogs had treatment intensified and were withdrawn from the comparison?
Sorry, can you repeat the first part of the question? I didn't get it.
Absolutely. So in the trial where izimid was compared to furosemide, there was a lower dose than we routinely use for starting cases of heart failure. And do you think this influenced the survival curve results?
Okay, right. Oh yeah, that's an important question because I show you the PK/PD study where they show that in an average, the average body weight dogs, they had to obtain around 4.8 or 60 ml per day of diuresis. You can actually have the dose of furosemide was something around 0.13 or 0.15. So you can debate and say maybe these cases were not very advanced. That can be an option for sure. But on the other side, I think that is when we want to use furosemide, and I actually kept saying during all my presentation is using when we want to prevent edema, or as we discussed this for B2 cases, the advanced B2 cases, or if you have cases, particularly cases when you have mild to moderate edema, and at that you can go with a first-line treatment. So we don't want to change the use of furosemide when should be used CRI and in the acute alveolar edema. So for sure can have an impact on the survival. Maybe there are some cases that was a little bit, less severely affected, but still, I really think that, and with the other studies we are right now doing in Italy, that using in the interstitial edema, it's a good way to go.
Sorry, I'm messing around with my audio there. Sorry about that. Thank you. So the next question is, having seen the information and evidence following the clinical trials with furosemide in dogs, do you think and would you welcome the opportunity for further study looking at furosemide in cats?
Oh, that's an interesting question. Obviously, we have, I mean, when I prepared this lecture about dogs, I also look around in the literature, and obviously we have some data about PK/PD, and I actually show you a slide on that. So it's very potent diuretic also for cats. But if you look on the use in treatment of heart failure in cats, there are just one poster, not yet published, and was presented last year in Milan in the ECVIM, and from the Maison d'Alfort group. And in this study, they show that particularly in advanced cardiac failure, the use of torsemide improved the condition of the animal compared to furosemide, and there was a good control of edema over time. Obviously, this was the beginning, just like we started in dogs. So we started using torsemide just in advanced cases, and that's what they did for cat. And I really think that in the future, we can also consider the use of torsemide in cats, but we need studies and see, because we know that also furosemide in cats, it must be used very carefully. So I want to see which low doses we need control edema without inducing any problem, just like we are now doing with low doses of furosemide. But I really think there is room to do a study in cats.
Okay, thank you. That's fantastic.
You're welcome.
So another question. Owners are used to giving furosemide twice daily. So often when I switch to furosemide, owners report an increase in respiratory rate in the evening and they give another dose. Therefore, I prefer to give furosemide twice and it works much better. Do you find you have a similar experience, or is once a day as effective?
Is this in probably is talking about, I think, class C or
stage D.
D. Okay, good. Okay, so, yeah, I mean, this depends. Obviously, you need really to be careful about the doses because you see, you can stay from 0.13 up to 0.26 in the maintenance dose, because when you go higher, then you have very, very inter-individual variability on the diuresis. And so we must be very careful when you use in class C higher doses. And particularly, we have most of the study has been done on a single dose per day. Then if you move to class D, then I mean, I'm okay with this. So what I suggest to the colleague is to check carefully about the doses that is using in morning, because if it's if it's the right doses. And again, I have cases, maybe I have to rise up to 0.2, but always below 0.26. And so I don't have the same experience if I use the right dose for the particular dog.
Okay, thank you. And do you notice an increase in nocturia with tirasemide, or perhaps less?
This is a good one. And at the beginning, I was scared about this because, for all of us, owners that have cat under loop diuretic therapy, it's a nightmare, during days and night. And so I was afraid that using a so potent drugs, that was the major problem. And I have to say that so far I hadn't a lot of, concern from the owner about, peeing everywhere during the day or the night. So I actually didn't notice a lot about this.
Okay, thank you. So the next question is from a colleague who uses butorphanol for control of cough in their patients. What is your opinion regarding the use of butorphanol in patients that have congestive heart failure and pulmonary edema? Should we stop butorphanol at this stage?
So the use of butorphanol in patients with acute edema is indicated. I mean, also the guideline, the 2019 guideline for treatment of acute stage C, they put butorphanol as probably the drug of choice. And then I agree with this colleague that particularly in some cases, and we all know that when the edema solved, then usually cough, it gets better, but it's not completely solved, because maybe there is a concomitant bronchomalacia, there are some other, bronchial issue together with the pulmonary edema. And so we do use, I have to say, in rare cases, butorphanol also chronically to control resistant cough. But for the acute stages, yes, I think it's the best drug to use, together obviously with I don't know about IV pimobendan all over Europe, but at least in Italy and in other countries, the use of IV pimo is helping a lot, together with the CRI furosemide and together with butorphanol to sedate the dog.
Excellent, thank you again. So I think this is the last question, unless anyone enters any more, but after this one. Someone was wondering if there is any clinical evidence or trials out there regarding the use of spironolactone in cats, and if you do use it yourself, and do you worry about things like the adverse skin reactions that were reported in a trial a while ago?
Okay, yeah, spironolactone in cats, there is one study where there is a decent amount of cats where they use it to control cardiac failure. And in these cases, in this study, there is a good result about using spironolactone. And so this is called the SACE-CAT study. But in this particular study, there is some rare adverse events, and all of us are very scared because there are some, data about cases where there is facial stretching and so on. But I actually haven't seen, and never have seen something like that. And for sure, I use spironolactone in cats, particularly in the new staging that we have now in cats. So it's also for cats staging cardiomyopathy. There is probably most of you already read this guideline. In class D, there is the use of spironolactone when there is diuretic resistance, when you have, pleural effusion with a lot of reoccurrences. I think there is a very good drug to use in that stages. We don't have studies for early stages, and I think that there is also room to do something for spironolactone in early stages.
Thank you. So the final and last question, I think, how do you change from furosemide to torazamide? For example, you have a dog with 3 milligrams per kilogram twice daily of furosemide, and it's not controlling the pulmonary edema. What would you do if you were switching it across to torazamide?
All right, so this is the good question, because this is a daily problem that we face. Obviously, we are talking about a class C, that if you consider for class C to go into class D, there is this cutoff that has been suggested from the guideline is 8 mg per kg per day. Here we are at 6 mg per kg per day. So we should consider this dog still in class C, but it's still in edema. So probably in such a case, we are considering diuretic resistance. So again, if you go back to my slide and you know all what I told you about the late breaking, about the aldosterone breakthrough and so on, for sure, if you're not using yet spironolactone, you should in such a case. But then if you want to switch to torsemide, this is the most difficult part, because I'm very confident now in using as a first-line treatment, and then to titrate the dose over time, then to switch. And if you now are using the 6 mg per kg total, the probably dose that you should use is a 0.3 per day. And a 0.3 per day in a dog that is still in congestion is already above the limit for, a good inter-individual diuresis. So what I would like to do in such a case is to start for 5 days in a higher dose, maybe a 0.3 or a 0.4, and then I go down to the maximal maintenance dose of 0.26 and see if it's enough. If it's not, then in my experience, this is not anymore class C. You are now in class D. And then at this point, I'm open to review the use of twice a day of torsemide, and then obviously checking the renal panel, because we know that a higher dose, you have higher diuresis, but you also have more possible damages on the kidney, exactly as furosemide. And there are cases where, this is my personal experience, and I know a lot of other cardiologists doing this, particularly in class D, where a very high dose of torsemide is not working, just using once a day, we are adding furosemide in the night. So trying not to, go too much with torsemide. But this is just personal experience, is not, there is no any studies in class D patients and over time with the use of neither furosemide nor torsemide.
Okay, excellent. So we have had a couple more questions, if you have time, Roberta,
Sure.
If that's okay. So with these recent studies, in your opinion, is torazamide more appropriate as a first-line treatment for pulmonary edema in dogs in stage C than furosemide?
Oh, this is a huge question. We have enough. We have enough data now that suggests that torsemide is not inferior to furosemide. Torsemide it's safe, short-term and long-term. At least, the longest studies it's almost 6 months now. And now we have other studies. With the clinical use, there will be done in most of the states. And I think we have enough data that is safe and is not inferior. And so I can say that sure, we can use it, but I cannot say that is wrong. You should not use furosemide. That I cannot say that. So, I think if I have to pick, I probably can pick torsemide with no problem. And the fact that we are giving torsemide once a day for sure it's good. Obviously, we have other drugs that we are giving twice a day, so for some owner doesn't make a major difference. But I think we have enough data to say yes, you can use it as a first-line treatment, and this depends to you and depends on how confident you will come over the days. And I think I'm one of the cardiologists that was very, very afraid about the use, and also my teams or in all the units where I work. But now, I mean, I feel more confident that no major problem we cannot find any major problem using as first line treatment in class C.
Thank you. So another question is, somebody has been using torsemide for more than 10 years and they do see hypokalemia as a common side effect in their cases, and they wondered if you see a similar problem in your cases.
Okay, this is a very interesting, because I've not been using so long, and so at least from all the studies that we have, there is no major hypokalemia. There is actually no major changes in all the electrolytes. I cannot answer, long term, more than the 6 months, but at least I have cases that now has been on torsemide for more than 8 months to 12 months, and I have not. I cannot get in my mind cases where I need to supplement potassium because of hypokalemia. So I don't think it was a major problem.
Okay, and is it better to give torsemide before or after food, or with food?
Sorry, say it again. That was the English. I couldn't.
Sorry. Is it better to give torsemide before food or after food? Or with
great.
food?
I got it. I didn't get the food. Okay. The possibility to give, and you saw from the carpodiem study, there was a good compliance of the dog and to get torsemide without food, so it's palatable. So there is at least, maybe I can ask help to Emily, but I'm not aware there is any difference in giving with or without food. But and for sure you can. Go ahead.
Yes. So, sorry, Roberto. In fact, there is no recommendation to give it with or without food in the SPC, because the difference is not that major, but in fact, the food tends to increase the bioavailability.
Okay, but there is no, from the clinical point of view, there is no major difference. And the carpodiem study showed that actually you can give without food, and there is a good percentage of dogs that got it without any problem. So, PIMO has this major problem that you have to give before and so on, but I wasn't aware about torsemide, so no problem.
Okay, so I promise this is the last question, and then we will close the session. You have mentioned the use of furosemide CRI several times in acute congestive heart failure. How do you decide when to start a CRI or continue with intermittent IV bolus?
Oh, I love this question, because I'm really a fan of CRI, as you probably understood. That's why you asked me. But we have been using CRI furosemide, I would rather say at least 5 or 7 years. And what I have to say, as I show by my graphs, that CRI keep the furosemide concentration in the bloodstream quite stable over time. We really like to start with just one IV bolus as soon as the dog came in, and we just give one bolus of furosemide at 1 or 2 mg per kg. We don't want, the breaking effect if you activate particularly if it's an acute onset edema without, any other ACE inhibitor or other drugs. And then we start with 0.7 mg per kg per hour. Usually we just check the respiratory rate. The dog, when he came, usually when he entered the hospital, is around 70 to 80, because we are talking about alveolar edema. And then we stop CRI when the respiratory rate is around 40, 45, something like that. And at that point, we don't use any boluses, IV boluses, and we just go for subcute shot for maximum twice, and then we switch to oral. And that's very important. Two things are very important here. One, be careful for the total dose of furosemide for the 24 hours. So you have to consider the CRI amount, the bolus, the initial bolus amount, and then the subcute. And so for a total dose that I really like to stay below, if I can, below 8, if I cannot, below 10 mg per kg per day. And if you go above that, you can start having problems. So, and then the other part is then if it's not using yet any, usually we start PMO IV in such a case if it was not on, and be careful with the ACE inhibitor, because if it's not on ACE, I know I really like in such a case, since there is a massive activation, to start, titrate the dose up. This is the only case we like to titrate the dose up, because you can have, acute decrease in renal perfusion otherwise. All right.
Okay, thank you, Roberto. Okay, so thank you very much for everyone joining us today. And I would like to take this opportunity to say a big thank you to Dr. Roberto Santilli for an excellent presentation. I have enjoyed learning about your experiences in using torazamide in dogs in all the aspects of heart failure. And we hope to hear you speak again on cardiology in the near future. Thank you to everyone who joined us for this live event today. If due to time we were unable to answer your question in this session, we will be in touch with you very soon with an answer from ourselves and Dr. Roberto Santilli. We will also share a recording with you in the coming week, so if you joined us late or missed a part of it or would like to listen to this talk again, there will be the opportunity. Lastly, please don't hesitate to contact your SUVA representative if you do have any questions following this event. And thank you very much for joining us today, and a special thank you to you, Dr. Roberto Santilli, for a fantastic presentation.
Thank you so much.
Thank you
so much. Have a great day. Bye-bye.
Bye.
Bye-bye.
Bye.